Welcome to the presentation for Nursing 150 Module 9. This presentation will discuss the cardiovascular system. We'll review the anatomy and physiology and the function of the cardiovascular system and the care of the patient with central perfusion issues. Central perfusion issues are ultimately what a patient will experience if there is a problem with the anatomy and physiology and the function of the cardiovascular system. The central perfusion discussed will be related to the heart itself and how the heart functions and when there's disorders of the heart itself. This is a review of the anatomy of the heart. The cardiovascular system is made up of the heart and blood vessels, the blood vessels being the arteries and veins. This system is responsible for supplying oxygen to body organs and other tissue. Oxygen in the blood is needed for cells to live and function properly. When diseases or other problems of the cardiovascular system occur, oxygenation and perfusion decrease. And this is usually the problem that we see in a patient. The priority concepts are oxygenation and perfusion. The myocardium is the heart muscle. It needs a supply of oxygen itself in order for it to function properly. These vessels that you see here on the surface of the myocardium are the coronary arteries, and those would be the red vessels there. Those are the vessels that supply oxygen to the myocardium or the heart muscle. It's important that those vessels remain patent and those vessels remain functioning so that the heart muscle itself has blood supply and oxygenation and perfusion. This is just a little bit different view of the coronary arteries. Really the purpose of this slide is to kind of visualize where the coronary arteries are and the main ones that we look at. If you look, this is the left main coronary artery. They all come off of the aorta. The left main coronary artery is a very important coronary artery. As you can see here, it branches off into three major other arteries. The left anterior descending is one that supplies the anterior portion of the heart. And if you think about the anatomy of the heart, this whole area here is the left ventricle. The left ventricle is the workhorse of the heart. It's the ventricle that has to pump blood out through the aorta, out to the rest of the body. And that's why it's imperative that that ventricle has patent blood flow to it, to the muscle, so that it can remain functioning well. If it doesn't function well, then we're going to have perfusion and oxygenation problems because if it's not able to pump blood out through the aorta to the rest of the body. And then over here is the major right coronary artery, the right coronary artery here that supplies mostly the right side and the inferior side of the heart. As we continue this discussion, we'll talk about if there is some kind of a blockage in one of these arteries, what that's going to mean for your patient. Blockage is going to be caused by an atherosclerosis or arteriosclerosis, which can be preventable or at least attempt to be prevented. And that's kind of the things that we're going to talk about throughout this discussion is how to prevent any kind of occlusions from occurring in these coronary arteries that will block blood flow to the heart, which can cause your patient to have a dysfunction in their heart muscle, which could lead to poor oxygenation and poor perfusion of the tissues. This is a review of the blood flow through the heart. I highly encourage you to kind of just go through this yourself. The arrows are pointing how the unoxygenated blood comes back to the right atrium, flows through to the right ventricle, up and out to the lungs. The blood is oxygenated in the lungs and then returns back to the left side of the heart and through the left atrium and out the left ventricle into the rest of the body. This has to occur in a nice organized manner for the patient to have adequate perfusion and oxygenation. Again, what we're going to talk about is if there's something that occurs that involves the process of this blood flow being efficiently done, and that could cause the patient problems with perfusion and oxygenation. So that's what we'll be discussing. So it's a good idea to understand the normal functioning of the heart. This is a visual picture of the cardiac conduction system. This is also necessary for the proper functioning of the heart muscle so that it can send oxygenated blood out to the tissues. The cardiac conduction system it consists of specialized myocardial cells. These cells have electrophysiologic properties that regulate the heart rate and rhythm and possess the unique properties of automaticity, excitability, conductivity, and contractility. Basically, what this is saying is that the automaticity is the ability of the cardiac cells to generate an electrical impulse that spontaneously and repetitively. This electrical impulse stimulates the contraction and basically the beating of the heart. The excitability means that it responds to the electrical impulse. So the SA node is actually the part that sits in the right atrium that generates the electrical pulse. And the excitability is what allows the rest of the cells to respond to that electrical impulse. So it starts here and it spreads down to the AV node. Depolarization occurs when the normally negatively charged cells within the heart muscle develop a positive charge. So this is kind of that excitability, and that has the ability to conduct it through. So these are unique cells. So basically, the automaticity is the ability to stimulate its own impulse. Excitability is the rest of the cells respond, and then we conduct it. The SA node, as you can see here in this part here, is the firing of the SA node is the P wave on an EKG. And basically what an EKG is our ability to attach leads to a patient's chest and be able to, through this machine, the magic of a machine, be able to represent it on a piece of special paper, the electrical activity of the heart. We must have electrical activity in order to have the mechanic ability of the heart to contract. So basically, we have to have the conductivity first, and then we have the ability to have the mechanical ability of the heart in order to pump the blood through. So continuing on with the EKG, basically what we see is the SA node firing here in the P wave, which means that the atria are contracting, and then the impulse spreads down to the AV node, which then spreads down to the ventricles, and that's when the QRS contract, and that's what your ventricles contract, and that's what you're seeing on your EKG is your QRS. And then the T wave represents depolarization of the ventricles. So that means the ventricles are going back to rest. So this allows us to see that that the conduction system of the heart is working as it should in the order that it should. So it's telling us that the SA node is sending the signal, it's sending it to the AV node and spreading down through the ventricles, and then so on and so on and so on. So what we can see with an EKG is whether this conduction system is working in the order that it should be, because if it is, then that helps us understand that the blood flow through the heart should be going through in a normal pattern. If we don't see this normal EKG, we can see that perhaps there's a problem in the conduction system for whatever reason, and it can help us understand maybe what we're seeing in our patient. And we'll talk about this a little bit more in class. We'll look at some EKGs and things like that and just kind of compare and contrast and walk through this. And this is just a summary of the cardiac conduction system. The SA node is what is the band leader, the pacemaker, the natural pacemaker of the heart, if you will. That's what we call it. This is where the impulses always start, and it's at 60 to 100 beats per minute. If you recall, a normal heart rate, and when we assess a patient, is considered to be 60 to 100 beats per minute. And that is represented, the SA node firing is represented on an EKG as the P wave. And So that would be the SA node firing. The AV node, or the atrioventricular junction, which meets right in the middle of the atria and the ventricles, is the PR segment on the EKG, and that's known as the atrial kick. So that's when the atria kind of kick the blood flow through to the ventricles. So I'm trying to, I'm not doing a very good job drawing this here. Let me start over again. So P wave. So the P wave is the SA node, and then the PR segment. So let's see. And then the bundle of his, when the bundle of his fire, they represent the QRS. So we have QRS and then T. So this is SA node. This segment here between where the P starts and the R is where the AV node fires. And then this whole QRS segment is the ventricles firing or contracting. And then this is when the ventricles rest. So we can see the time frame that this occurs, and it should happen 60 to 100 times a minute. The SA node should fire 60 to 100 times per minute in order for a patient to have a normal heart rate. This is what this would look like on a EKG. So you can see we have a heartbeat here, we have a heartbeat here, we have a heartbeat here. And then all of this 3 seconds and everything, that helps us to be able to count to determine the heart rate. And then what the other thing we're looking for is, see here, we have a P wave, we have a QRS, we have a T wave. So that's a normal heartbeat. Then again, we have a PR, QRS, T wave, PR, QRS, T wave. So that's what people are looking at. It does appear that we're having normal heartbeats, and then we would look at the rate to determine if it's coming in too fast or too slow. Remember, if it's coming in at less than 60 times a minute, if it's coming in at less than 60 times a minute, then it's a bradycardia. If the SA node is firing greater than 100 times per minute, then that is a tachycardia. This slide, it's a little bit hard to read because it's kind of small, but again, it's just kind of going over what I just talked about, how the P wave represents atrial depolarization. Depolarization means it's changed from a negatively charged ion to a positively charged ion, which is basically the excitability of the cardiac cell. The PR segment is looking at the time it takes for that impulse to travel from the SA node to the AV node. And then the QRS complex is the ventricular depolarization. That's when the ventricles fire. They go from a negative to a positive charge and fire. And then the T wave comes back to repolarization. And sorry, I said that wrong on the last slide. It's repolarization, not depolarization. Repolarization means rest. So that's when the ventricles come back to rest. So it tells us this is when the ventricles fire. And then this tells us how long it takes the ventricles to come back to rest. So that can be important for us to kind of look at to see the work of the ventricle. And again, like I said, we'll cover this in class and kind of work through this together in class. This is just a little slide for you to see what a sinus bradycardia would look like. So it looks, you can just by looking at it tell that it's slower. And then these are the regular heartbeats. You have a P wave, QRS, a T wave, P wave, QRS, a T wave. And it's just coming in at a slower rate. And just by looking at this, you can kind of see that the heartbeats are coming in faster. And this is a tachycardia. It means that the SA node is firing more than 100 times per minute. There's lots of things that can cause these different types of arrhythmias, and we've talked about them. Like hypovolemia can cause a tachycardia. Thyroid storm can cause a tachycardia. A fever can cause a tachycardia. So there's lots of issues that can cause this, and this is what it would look like on an EKG when your patient is tachycardic. Cardiovascular system assessment is going to review patient's history, things in the patient's history that are going to put a patient at risk for having some kind of a cardiovascular problem. Typically, when we're talking about the cardiovascular system, we look at modifiable and non-modifiable risk factors. Modifiable means that you could modify something in your life that could possibly decrease your risk for a disease. Non-modifiable means it's something we have no control over. Non-modifiable is going to be your age. We can't change that, unfortunately. We haven't figured out how to do that yet. Hopefully soon. Your gender, your ethnic origin, and the family history of cardiovascular disease. Your family history is your family history, and it's you can't change that. Um, and and then and that's when we're talking about family history, we're talking about a history of any kind of coronary artery disease, any kind of cardiovascular problems. It does appear that there is definitely a genetic link to cardiovascular problems. The risk is higher in a patient who has a first degree relative that had coronary artery disease at a young age. For instance, if a patient comes in and you ask them about their parents and they say, my father died of acute coronary syndrome at age 50, that puts the patient at significant risk for cardiovascular issues, and we're going to watch them very closely. A coronary event at a young age of a first degree relative kind of puts them in a special category. Postmenopausal women are 2 to 3 times more likely than a premenopausal women to have coronary artery disease. It does appear that men have a higher risk for coronary artery disease than women of all ages, except as women get older. When women get 80 years or older, the risk is the same for both genders. Heart disease is the leading cause of diabetes-related death for both men and women. So diabetes puts a patient at high risk for stroke and cardiovascular diseases. Moving on to some more modifiable risk factors, cigarette smoking is a major risk factor, of course, for coronary artery disease. And as we continue to talk about atherosclerosis and arteriosclerosis, we'll see how smoking affects that. Sedentary lifestyle is a risk factor. That's why we recommend that people get up and move. It helps your heart. It gets your heart into shape. Your heart is a muscle, and it needs to be worked. It needs to be trained and get into good shape because, again, it is a muscle. We need to take good care of it. American Heart Association recommends that people take a 30-minute daily of light to moderate exercise. You could take a 30-minute brisk walk daily, and that could decrease your risk factors. Obesity is defined as a BMI greater than 30 by the American Heart Association. Obesity is also associated with high blood pressure, high cholesterol, and diabetes. So all of these things are risk factors for coronary artery disease. American Heart Association is a wonderful guideline for looking at patients and looking at information related to cardiovascular diseases. They provide guidelines to help patients with obesity. They recommend that patients, and then we're moving kind of into the nutritional history part here. They recommend that patients have nutrient-rich foods, with minerals, high fiber, and nutrients that are low in calories. And that's just basically just a healthy diet. We need to have high fiber, high vitamins, low calories, low fat, choosing foods like vegetables, fruits, unrefined whole grain products, fat-free dairy products. And it's a really good idea if you get the opportunity to look up the American Heart Association and their dietary guidelines in order so that you can help a patient understand what is healthy dietary guidelines. Stress is a factor that plays a part in a patient's risk factors for cardiovascular disease. High stress jobs, those type A personality patients are, it's found that they have more of a tendency to have cardiovascular problems and have coronary events. And it's due to that constant state of agitation and whenever you're aggravated, stressed, your body requires oxygen. because your heart rate goes up, you're tense, and so that requires more oxygenation to the heart, and that can cause some chest pain, shortness of breath, palpitations, things like that. All this catecholamine response. Remember those catecholamines from your adrenal glands, those epinephrine and norepinephrine, that's kind of that fight or flight stance. That causes your heart to race, your vessels to constrict, and that causes a strain on your heart. So all of those things together can be a risk factor. And then, of course, you're looking at a patient's, their current chief complaint. Are they coming in complaining of shortness of breath, chest pain, fatigue, palpitations, having increased edema, having episodes of syncope, which means, like they pass out or have a brief loss of consciousness, extremity pain. As we go in further talking about like angina and things like that, you'll learn that a pain that maybe starts in the chest and kind of radiates out through the neck and through the arms is indicative of some possible issues with the heart. So we'll continue to talk about these. So you just kind of also look at what the patient's complaining about, their current chief complaint. We've spoke about this in class before, but I thought this was a really good slide to kind of help patients and nurses to understand that fluid is the best indicator of weight, whether someone is retaining water, which can be a helpful assessment in a patient with cardiovascular issues. Basically what this is saying, that 1 kilo, so a weight gain of 1 kilogram is equivalent to 1 liter of fluid. So if a patient gains 2 kilos overnight, then they are holding on to 2 liters of fluid, and that just helps us to understand their fluid balance. It's a more and better indicator than just taking eyes and nose, because sometimes we miss things when we do eyes and nose and we kind of estimate and things like that. So the weight is a good way to identify whether someone is indeed holding on to water. And this slide is just a reminder to kind of think about, okay, what kind of signs and symptoms would you see in your patient as they come in and maybe they're complaining of shortness of breath? What kind of general appearance things are you going to look at? You look at the color of their skin, because that is an indicator of oxygenation and perfusion. If they're pale, if they're, clammy, if their nail beds are pale or they're gray or dusky, that tells you that for whatever reason they're not getting oxygenation and perfusion to the periphery. So could it be a heart problem? Where's the problem coming from? Edema in the extremities and clubbing can be indicative of a patient who is, for whatever reason, have a fluid balance problem. Fluid accumulation in the legs can be indicative of a cardiovascular problem. Especially if it's dependent in the lower legs, that means the blood flow maybe is pooling in the lower extremities, not getting back up to the heart, and so we need to investigate that. Of course, your blood pressure is going to help us identify whether a patient is having cardiovascular problems, low blood pressure or high blood pressure, and we'll talk about that as well. I wanted to put this slide in here because a lot of students have difficulty understanding the different terms that we use for disorders of the central perfusion organs. Coronary artery disease is an umbrella term, and what it's talking about, what coronary artery disease is referring to, is when, remember that slide I had with the coronary arteries that supply blood tissue oxygenation to the heart muscle? That's when there's a disease of those arteries. And we'll talk about the disease of those arteries can be caused by an atherosclerosis, which is a buildup of plaque and cholesterol in those vessels that causes to have coronary artery disease. So that's essentially what we're referring to. There's plaque buildup. There is cholesterol buildup within the walls of those coronary arteries due to, like we talked about, the risk factors. Maybe it's family risk factors. That stuff begins to occur as we get older. Those things occur resulting from a high cholesterol level. They occur as a result of diabetes, uncontrolled diabetes. They result of a sedentary lifestyle. They're a result of obesity and eating lots of fatty foods that increases our cholesterol, things like that. So when we say CAD, coronary artery disease, we are talking about the arteries that supply oxygenation to the heart muscle have a disease in them, and the blood flow is not getting through to the heart muscle. When that disease process first begins and the lining of the vessel wall is becoming somewhat narrowed, and we have some slides, and we'll look at the American Heart Association, some pictures there about what this looks like. When those coronary arteries begin to have some narrowing due to plaque buildup, due to cholesterol buildup in them, the patient will have something called stable angina. And basically what that means is the heart is getting a supply of oxygen. However, there's a vessel that's narrowed that in times of stress, in times of exertion, the heart will actually have difficulty getting that blood flow to the myocardium, and the patient will experience a little bit of chest pain as a result of that. So let's just kind of review the anatomy and physiology and the function of the heart muscle. The heart is a muscle. It requires oxygen to be perfused to it. It requires a constant supply of oxygen for it to be able to function properly. When you have coronary artery disease, you can have an imbalance of oxygenation. So the heart muscle constantly needs oxygen. In times of when we have an increased O2 demand, which might mean that you walk up a flight of stairs. So walking up a flight of stairs would increase your oxygen demand because, that activity causes more oxygen. So when you have increased oxygen demand and you have this maybe narrowed vessel that's only allowing about half of the normal blood flow through, then you are deprived of that oxygen that you need. So this imbalance of oxygen supply and demand causes an angina. And that angina is a result of what we refer to as kind of some ischemia. Ischemia means a poor blood flow to an area. So, and basically what happens in a stable angina is if I climb a flight of steps, I get a little chest pain because now my oxygen demand is higher than my oxygen supply. If I sit down at the top of the steps, then I can kind of catch up. My demand will go down and my supply will increase because now I can get more in balance if I sit down and relax and catch up. So that's a stable angina. So that means that if I have a little chest pain with increased activity, then I can sit down for a few minutes and I can relieve that pain. And what that pain and what that's all about is the supply and demand of the myocardial tissue of oxygen demand. So as I went up the steps, my demand increased, my supply was lower. As I sat down to rest at the top of the steps, then my O2 demand decreased and my supply became appropriate then. Again, we'll talk about this a little bit more in class. And I have a few slides coming up that kind of depict the atherosclerosis disease in the arteries. Acute coronary syndrome is referring to the fact that eventually this plaque can continue to build up, especially if the patient doesn't do anything to change their lifestyle or especially if they don't do anything to prevent it. And that plaque can continue to build up in the vessel wall and actually completely occlude that vessel wall. And then the patient will continue to have a disbalance, an unbalance between their oxygen demand and their oxygen supply. So when we talk about acute coronary syndrome, it is a bit of an umbrella term over unstable angina. So the angina can become unstable to where the pain does not go away with rest. It may occur at rest, It can occur at any time, and they can't get rid of it with rest. So it's basically now unstable, and it usually becomes unstable because that coronary artery has become much more diseased, and only a little bit of blood supply is getting through that diseased vessel. And so the oxygen demand of the patient is much more than the oxygen supply due to the narrowing of the artery. A myocardial infarction occurs when that vessel is completely occluded. There is no blood supply that can get through to that area of the heart muscle. And so an infarction means a complete death of tissue. A myocardial infarction occurs when myocardial tissue is abruptly and severely deprived of oxygen. When blood flow is quickly reduced by 80 to 90%, ischemia develops, and ischemia leads to an injury and necrosis of the myocardial tissue. And I have some slides here that kind of help look at that a little bit further, but I kind of wanted to just do this slide to kind of help you understand the different terms. And this is just kind of, again, kind of reviewing all those terms. Coronary artery disease includes the term stable angina and acute coronary syndromes. And remember, what's under acute coronary syndromes is also an unstable angina and myocardial infarction. It's important to understand the term ischemia. It means insufficient oxygen supply to meet the requirements of the myocardium. Remember, it's an imbalance of supply and demand. Infarction means necrosis or cell death that occurs when severe ischemia is prolonged and decreased perfusion causes irreversible damage to the tissue. So this is when there's so much ischemia that now there is actually damage to the tissue because of the deprivation of oxygen to the tissue. Ischemia means it's being deprived and it's in trouble. So here's that slide with the plaque buildup within the arteries. This can happen in any of your arteries throughout your body. For this purpose, for this class, we're just going to discuss the coronary arteries. So this is that liquid deposit of plaque within the intima of the arterial wall. And this is cholesterol buildup in here. And then that's why we really talk about high cholesterol levels being a risk factor for coronary artery disease. And as we have some more slides here that kind of depict how this deposit of plaque can begin to cause deprivation of blood flow to the heart muscle, and then how it can get worse and cause an infarction. So what would be occurring here is maybe since we have some occlusion of the artery, then this patient might experience some stable angina with extreme exertion. They might start to feel that oxygen demand imbalance at extreme times of exertion, and then they would be relieved by rest, because then they can get their balance of oxygen supply and demand back when they rest. So this slide is kind of depicting on how this process of atherosclerosis and blockage of the arteries occur. So this is when the cholesterol particles begin to make deposits within the arterial wall, and then now it's kind of developed into a little plaque area, and it can continue to develop. Now we're 50% blocked. This is your patient that's going to have stable angina. They'll get it with extreme exertion. It can be relieved with rest. As you can see, the plaque has continued to grow here, and there is a severely there's a severely occluded artery there, and like this says, it's 90% blocked. That patient is going to begin to have signs and symptoms of unstable angina, because it's going to be very difficult to get adequate blood flow to the area of the heart that this artery supplies. The other thing that can occur sometimes, if this plaque becomes unstable and breaks off, our body goes into a kind of a series of inflammatory responses, it sends in platelets. And remember that inflammatory response where we send in platelets, white blood cells, inflammation occurs. And that occurs in response to maybe the breaking off of the plaque, which the body identifies as an injury. The plaque can actually injure the arterial wall, so the body identifies it as an injury and will send down platelets. And we know that as platelets form together, they form a clot. And so basically it's kind of like when you cut yourself, when you know how you bleed a little bit and your body sends like platelets to clot it. That's what happens, and that in turn will completely occlude the artery. This is where a patient is going to have a myocardial infarction because that area of the heart will be completely deprived of oxygen. This slide is just another explanation and definition of chronic stable angina. Pectoris is referring to the chest. So angina pectoris basically means chest pain. Strangling of the chest, kind of that strangling feeling. A lot of times people will say that it's kind of like pressure. A lot of women will say that they feel kind of like a choking sensation. It's kind of that like pressure on their upper chest area that they'll feel. And again, it's a temporary imbalance between the coronary arteries' ability to supply oxygen and the cardiac muscles' demand for oxygen. Again, imbalance between the oxygen supply and demand is the problem here. In this case, it's temporary. If they sit down and rest, that balance can return. Ischemia is limited in duration and does not cause permanent damage. Again, those two words, temporary and not permanent, are important to understand with stable angina. Acute coronary syndrome is a term that's utilized to indicate that we now have an unstable angina. So now the pain is occurring at rest. It cannot be relieved by rest, and that's because probably the atherosclerotic plaque in the coronary artery may rupture, resulting in this platelet aggregation that comes down and forms a clot and causes a complete occlusion of the coronary artery, which would be could end in an acute myocardial infarction, which could mean permanent tissue damage. This is just another definition of the unstable angina. New onset angina is usually, maybe this just comes out of the blue because as in contrast to the chronic stable angina, they start to get it and they're kind of used to it. They're like, oh, I got some chest pain. I'm going to sit down. I'm going to feel better. This can happen like they've never had before. It's chest pain that occurs, new onset. It cannot be relieved by rest. Things like that. It can be denoted as a pre-infarction angina, and if you recall how we said that the non-stable angina means that the occlusion is pretty big now, and it can lead into an infarction if we don't do interventions quickly. And the reason we want to make sure that they don't have an infarction is because we know that infarction can lead to permanent tissue damage of the heart muscle, which can lead to heart failure. So we need to identify an unstable angina quickly and treat it quickly so that it doesn't become an infarction. Variance Prinzmetal's angina is kind of just a specific term for chest pain that means like spasms. Spasms of the arterial wall, and that's due to the thrombus, the clot there. And that can be due to some other different arrhythmias and things like that. It's usually discomfort resulting from coronary artery spasm and typically occurs after rest. It's just a specific type of angina, which can mean like a pre-infarction. This is where we can start to see some EKG changes on a 12-lead EKG, and that's why we always order when somebody comes in with chest pain. We usually order a 12-lead EKG so we can see. And we'll talk about this a little bit later in the slides about why ST changes on a 12-lead EKG would help us to diagnose and treat a patient with unstable angina. The term myocardial infarction is referring to the abrupt and severe deprivation of oxygen to an area of the myocardium. Blood flow is quickly reduced by 80 to 90%. Ischemia, which means a lack of blood supply, can develop, which can lead to injury and necrosis of the myocardial tissue if blood is not restored. Myocardial infarction is further divided into a non-ST elevation myocardial infarction or an ST elevation myocardial infarction. On the next slide, we'll discuss that further. But essentially what that means is whether we see ST elevation on a 12-lead EKG or not. And like I said, we'll discuss that on the next slide. Some of the terms on here, subendocardial, transmural, and inferior wall MI, are discussing how much damage has been done to the heart muscle by the infarction. Often, myocardial infarction begins with the infarction of the subendocardial layer of the cardiac muscle. So that's exactly what it's referring to, is that there's an infarction of the subendocardial layer. This layer has the longest myofibrils and has the greatest oxygen demand and poorest oxygen supply, so that's often where it begins. Transmural MI is describing a larger area of infarction. Inferior wall MI is just essentially that. It's talking about an infarction of the inferior wall of the MI, and you'll hear different terms referring to where the infarction occurs. You'll hear lateral wall MI, anterior wall MI, and it's just talking about where they have found that there has been damage to the heart muscle. Ventricular remodeling is talking about the process that occurs when the heart muscle has been damaged. Scar tissue permanently changes the size and shape of the entire left ventricle when the left ventricle has been damaged. It's called ventricular remodeling. This remodeling may decrease the left ventricular function and lead to heart failure. This process and all of these terms are described in your book if you have further questions about them. It's really not something that you need to memorize. However, it's something that you need to know occurs because what we're going to talk about in the next few slides when we talk about myocardial infarction and coronary events is that time is muscle. The sooner that we get a patient into a ER and get them treated, the less damage can occur. So the longer that heart muscle is deprived of oxygen without treatment, there's going to be more damage to the heart muscle. So really our goal as providers is identifying a patient who is showing signs and symptoms of possible ischemia and unstable angina so that we can get them treated appropriately so that we can make sure that they don't have prolonged deprivation of oxygen to their cardiac muscle. The purpose of this slide is just to kind of help define the difference between a non-ST elevation MI, or otherwise known as a non-STEMI, or a STEMI, an ST elevation MI. So what you can see here, it's typically talking about the zone of injury or zone of ischemia. If an area begins to have episodes of ischemia, which we know is some slight deprivation of blood flow, the EKG will show a depressed ST, so ST segment. So remember that normal EKG, P wave, QRS, this isn't very good, sorry, and a T wave. What will happen if somebody's having some episodes of ischemia, we'll do a 12-lead EKG. Basically, a 12-lead EKG is hooking up leads to a patient's chest, and then we are able to see the electrical activity of the patient's heart muscle. And so if we start to see, if somebody comes in with some chest pain, we can see some ischemic changes on their 12-lead, then we know that there's actually some areas of the heart that are experiencing ischemia. So this is a somewhat normal EKG anyway, and then this is what it would begin to look like if there's ischemia. If injury is starting to occur, so now the blood deprivation, the blood flow is blocked so much that now the patient is experiencing so much deprivation of oxygen and blood flow to an area of the heart, it's starting to show injury. The T wave which is here, on a normal EKG will actually begin to look elevated. So that's a ST elevation here. Zone of infarction tells us that there is now an infarction occurring, and we know that infarction means injury. So it's the first signs of injury occurring in infarction is. So now the blockage to that area of the heart is so big that now that area of the heart is not getting enough blood flow, and now we're actually experiencing injury. So now we have ST elevation. So that's what we're looking at when we look at a 12-lead EKG. Do we see ischemic changes? Do we see ST elevation? If we see that, we need to go take them to a procedure that we'll talk about in the next few slides is a cardiac catheterization. We'll go take them to the cath lab, and we're going to actually go in and look at their vessels and see if there is a blockage within one of their coronary arteries, and we're going to try to open that up. We're going to try to regain blood flow to that area of the cardiac muscle. If we can do that quickly, we can prevent permanent damage from being done to the heart muscle. So that is our goal. Whenever we have a patient, we want to take a look and see if there's any ST elevation occurring, because that is a direct indicative sign that someone is about to have permanent damage to their heart muscle. This is just some more EKG tracings to show you what we are looking at exactly when we see an ST elevation. ST elevation indicates that there is cardiac muscle damage occurring. And remember, the depression in the ST segment tells us that there's ischemic changes going on. So that would be a non-STEMI. Non-ST elevation, positive ST elevation is why we use a 12-lead EKG in determining whether a patient is having a myocardial infarction or not. So these are the risk factors for a patient having a myocardial infarction or having cardiovascular disease. We've already kind of talked about them. Age, gender, family history, and ethnic background are non-modifiable. We know the older that we get, the more at risk we are for having the development of plaque forming within our arteries. And that is atherosclerosis. We also, as we go older, our arteries thicken and harden. And that's arteriosclerosis. So it's a combination of the plaque buildup and the hardening of the arteries that make them more at risk for injury and at risk for becoming blocked. Gender, we know that men as a whole are usually more at risk. Women become almost as equal risk as they get over 70 years old and 80 years old. They become an equal risk, but for the most part, men are usually at more risk. We also know that if you have a first-degree relative that had a coronary event or a history of cardiovascular disease at a younger age, that increases your risk for developing it as well. It's also important to know, kind of going back to gender, that women experience a little bit different signs and symptoms of chest pain. They often present with what we know as a triad of symptoms. In addition to indigestion or feeling an abdominal fullness, chronic fatigue, despite rest and feelings of inability to catch their breath, are also common in heart disease in women. The women may also describe the sensation of aching, choking, strangling, tingling, squeezing, and constricting or vice-like area. And it's sort of vague to them. It's not that, because men will come in, they'll say, there's an elephant sitting on my chest. That's a classic complaint of men. Women will say, I have this like kind of weird like choking feeling and kind of squeezing feeling. So it's kind of difficult. But when a woman comes in and tells us that, we need to be on alert that it could be signs and symptoms of ischemia or an unstable angina. We also know that elevated serum cholesterol puts a patient at risk for having those plaques form within their arteries, especially their coronary arteries. So we know that that is modifiable. We absolutely have measures to decrease a patient's serum cholesterol level. It can be diet, it can be exercise. We also have medications The most famous ones are the statins that are listed on your topical outline, and we're talking about pravastatin, atorvastatin, simvastatin. Those are medications that we can actually start a patient on to modify that risk factor. We know that cigarette smoking, if they stop smoking cigarettes, that can decrease their risk. High blood pressure causes a risk for the development of arteriosclerosis, which means the hardening of the arteries. Uncontrolled diabetes absolutely can lead to the buildup of plaque and the damage to your vessels due to the elevated blood sugars. We know that increased activity can help get that heart muscle in shape. Stress is one that a lot of people forget about. I'm telling you, I've had patients who, they're pretty healthy, but maybe they're burning the candle at both ends. And they're that type A, and maybe they're a smoker on top of it, and they're working hard. And those are the ones that we see in the ER a lot. A stressful event occurs, and it triggers it. That vasospasm in their coronary arteries, that oxygen demand decreases so much, it increases, oxygen demand increases when somebody's in a stressed situation. But it's one that we forget about, but man, it can really put somebody in a position to have a heart attack. So these are some actual labs that we can do. So let me kind of walk you through a scenario to kind of help pull all this together. If we have a patient that comes into possibly an urgent care, says they feel like they have an elephant sitting on their chest, have this pressure in my chest and I'm short of breath. And questions that we have for them is, when did it start? What were you doing when it started? How long has it been going on? Is there anything you can do that helps subside the pain? Does it go away with rest? What makes it worse? You ask them all those questions. And then the next questions you're going to ask is talking about risk factors. Okay, what kind of medicine are you on? What kind of family history? What kind of medical history do you yourself have? What kind of medication are you on? Are you diabetic? Do you have hypertension? And we're like, this guy, if they say yes, we're like, okay, major risk factors. All right, let's get some oxygen on the patient. It's always, always important to apply oxygen to your patient who is telling you that they're short of breath and that they have chest pain. Because let's rationalize this out. What causes the ischemia and the angina is the lack of oxygen to the heart tissue. So we basically have an imbalance in oxygen supply and oxygen demand. So let's slap some oxygen on them. Put, regardless, if their sats are 100%, we're still going to put some oxygen on them because we are going to try to attempt to help meet that oxygen demand if that's what's going on here. So we'll put 2 or 3 liters on them just to kind of give them some extra supplemental oxygen. The next thing we're going to do is we're going to give them some medication. It's called nitroglycerin. And I think it's in the next few slides. Nitroglycerin is a nitrate. When you say nitrate, that means that it vasodilates the vessel. So remember, our problem is we have this vessel, this coronary artery that's supplying the heart muscle with oxygen, blood supply. So part of it is occluded, more than likely. That's what's going on. So if we give them some medicine that can kind of dilate this vessel a little bit and maybe just get a little bit more blood flow to the heart. That's what a nitrate does. That's a nitroglycerin. It vasodilates, and hopefully it can allow more blood supply to that area of the heart that's being deprived. And we'll talk about nitroglycerin a little bit more in the next few slides. The other medicine that we might give to them is a 325 milligram aspirin. Aspirin is not for the pain. Nitroglycerin is, and it's also to help. The nitroglycerin is to help relieve the chest pain. Aspirin is a non-steroidal anti-inflammatory medication, but it also has this effect called a platelet aggregate inhibitor. So it inhibits platelet aggregation. Okay. So remember what happens, what we said inside that vessel when a plaque, a piece of plaque kind of breaks off into the vessel and it creates an inflammatory response where our body sends in all these platelets that cause a clot. Aspirin is thought to prevent the ability of the platelets to clot, thereby decreasing the likelihood of the thrombosis if we give them a 325 milligram aspirin right away. American Heart Association says if a patient has new onset angina at home, teach them to chew a 325 milligram aspirin. The antiplatelet effect of aspirin begins within 1 hour of use and continues for several days. Your book also says that the Joint Commission in a hospital setting says that aspirin should be given upon arrival to the emergency department when a patient presents with signs and symptoms of a myocardial infarction. We usually instruct them to chew it and swallow it. I can't imagine what this tastes like, but I've heard it tastes pretty bad. However, they think that chewing it and swallowing it will make it effective quicker, and we need fast action. Remember, we got to make sure that we get blood supply back to that area of the heart, and so that's why we tell them to chew it to see if we can get it to work quicker. Okay, back to the serum markers of myocardial damage. There are blood tests. When a patient presents to us with signs and symptoms of angina, maybe an unstable angina, remember that means that it's unrelieved by rest. It's new onset, perhaps. We put oxygen on them. We give them a nitroglycerin. We give them some aspirin. We get a 12 lead EKG. 12 lead EKG will tell us if there's any ST elevation or not. Our priority really is that pain control, and nitroglycerin will do that for us. So we want to make sure, because pain, if you know, increases your stress level, it increases your oxygen demand. So one of the priorities is getting the oxygen in by applying oxygen, getting pain control with nitroglycerin, preventing that clotting cascade or that platelet aggregation with our aspirin. And then we grab a 12 lead EKG, we grab that person to come in and do a 12 lead for us to determine whether there's ST elevation or not. The next thing that we're going to do is get blood drawn. We're going to draw troponin levels. Troponins are myocardial muscle protein released into the bloodstream when injury to the myocardial muscle occurs. They are not found in healthy patients. So all of us, you and I, as healthy heart patients, should not have any troponin. Our troponin level should be 0, nothing. Any rise in the values indicates cardiac necrosis or an acute MI. Specific markers of myocardial injury are troponin T and troponin 1. We usually use troponin 1 in practice. They have a wide diagnostic time frame. And it makes it useful for patients who present several hours after the onset of chest pain, because basically what happens is they start to rise as soon as there is some kind of myocardial injury. They will continue to rise, and they usually peak at about 12 hours, and then they drop down over a 24-hour period. So essentially what they do is they help us to kind of it's timing, and it just also confirms what we suspect. If we suspect that someone's having myocardial injury and we draw some blood and check their troponin 1 and there is an elevation in it, then we will know, that will help us to confirm that a patient has some myocardial injury. The creatinine kinase is also an enzyme specific to the cells of the brain, myocardium, and skeletal muscle. Elevation in your creatinine kinase will also kind of support the fact that there has been a cardiac event. It also helps with timing. We know when it peaks and when it drops back off, and so we can kind of see like timing, especially if it's somebody who's been having chest pain for a long time and doesn't come in right away. We can kind of see maybe like exactly what time the actual infarction or the injury occurred by the timing of the peaks and drop-offs of this creatinine kinase levels. We also will go ahead and check a cholesterol level, especially if it's somebody who has no idea whether they have high cholesterol or not. That, again, is just a supportive information to help us support whether somebody has those risk factors, and then this is indeed a coronary artery disease. Homocysteine and highly sensitive C-reactive proteins is, again, just a blood test that would be supportive. There are other things that can cause elevations in both these labs, so they're a little bit controversial. But again, if you have that patient that is coming in with all these risk factors, all these signs and symptoms going on, the homocysteine and the C-reactive protein will just support what's going on with them. Homocysteine is a amino acid that's produced when proteins break down. It's thought that patients who have a high level of homocysteine puts them at higher risk for having a premature heart disease. And C-reactive protein is usually in relation to inflammation that's going on in the body. It's an inflammatory process, can produce CRP. So coronary artery disease and atherosclerosis is thought to be somewhat of an inflammatory process. Remember, it's that plaque buildup and that inflammation of the inner lining of the arteries that can cause the blockage. So there's a lot of people put together the CRP elevated levels means that a patient probably has an inflammatory process going on that could be indicative of coronary artery disease. Usually it's those patients who have a significant family history of coronary artery disease. They have high cholesterol, they have a sedentary lifestyle, perhaps they have diabetes, and then if they also have an elevated C-reactive protein level, then the provider is going to say, you have all the risk factors, you have all the things that point to the fact that you are going to have a heart attack if we don't change your lifestyle, if we don't get your blood sugars under control, if we don't get your cholesterol under control. This is how this lab is kind of utilized in this situation. So this slide, the last slide, was kind of a general group of laboratory tests that we could use as far as risk factors, screening, and diagnosis. This one is more specific about the diagnosis if somebody is having a myocardial infarction or somebody's having a cardiac event. Again, remember, these troponin levels will begin to increase when there's any kind of myocardial injury. In a normal person, it should be 0. If it is elevated, that means that there is some kind of a myocardial injury. CKMB is also utilized to help us to support that there's been myocardial injury. Here's the difference between the two. Troponin levels will elevate quickly. The CKMB, the creatinine kinase, so the CKMB is more specific to myocardial muscle. The only thing about that is the elevation with the CKMB takes longer. So the troponin will elevate quicker. So that's why we use the troponins in an acute situation with somebody's coming in with an unstable angina. We'll do a troponin. And then we might actually go ahead and draw a CKMB, but we really don't pay as much attention to it if we're trying an acute situation to determine whether somebody's having a cardiac event, because the elevation in the CKMB will not occur as quickly. Again, both of them may be done in a situation, and it's all about timing. They might go ahead and grab a CKMB, not to help diagnose what's going on with the patient, but more to kind of help us time out when it happened a little bit more accurately. If you look in your Silvestri book, and it talks about the difference between CKMB and troponin, the troponin is likely to rise within 3 hours and persist for up to 7 to 10 days. Your CKMB, an elevation occurs within hours and peaks at 18. So the CKMB, it just says within hours. It's a little less specific, so that's why we kind of use the troponin as a diagnostic tool, and then the CKMB as a supportive tool. Again, notice the normal value for a CKMB is 0 to 5%. So any kind of an elevation would indicate that there has been a cardiac event. Myoglobin is another supportive blood test that might be done because it's an oxygen binding protein found in the cardiac muscle. The levels will rise within 2 hours after cell death. Again, it's just another supportive test that we would do. When speaking about blood tests, of course, we will also do like a CBC, and we'll also do electrolytes when assessing someone that's coming in maybe with an unstable angina. We've already talked about the 12-lead EKG. I don't know if any of you have had the opportunity to see a 12-lead EKG be done, but it's essentially what the 12-lead, why we call it 12 leads, is because it shows 12 different views of the conduction cycle of the heart. And we'll talk about that a little bit more in class. It's basically like 12 different pictures of what's going on within the conduction system of the heart. It gives us a really, really good example of what's going on within the conduction system. You see patients on monitor. Some of you are on telemetry units where they have the telemonitors. Those monitors are constantly monitoring an EKG on a patient, but it's usually a 3-lead or sometimes a 5-lead. Those will only show us 3 different views. And that's why even if somebody's on a telemetry monitor, we'll still do a 12-lead just because it gives us a better, more specific picture of what's going on with the cardiac muscle and the conduction system. Cardiac catheterization is the procedure that we may take a patient for if we determine that there is a cardiac event going on. And we'll talk about that a little bit more specifically in the next few slides. So this is, again, exactly the acute management of a patient who comes in and presents with perhaps an unstable angina or what we think is a myocardial infarction. Again, applying this. These are not in any specific order, so just make sure that you know that all of this is kind of occurring in a kind of a cumulative manner here. Usually we apply oxygen first because, again, oxygen supply and demand is a problem, but also because it's easy. Usually if you've got somebody that comes in an ER, we've always got oxygen set up, so let's just throw some oxygen on them. It's quick, it's easy, and it's what they need, right? Getting them in a position of comfort. Try to stay calm because we know, again, oxygen supply and demand is a problem. If we get them all riled up and we're all freaking out, it's going to get their heart rate up. It's going to get them all. So you got to just stay calm and calmly talk to them. Explain that you're going to give them the nitroglycerin, which is that nitrate, which can help with pain management because that's our goal. Remember, we want to keep their pain under control. We give them that nitrate, and that nitrate will vasodilate that vessel that's occluded, hopefully, and allow more blood flow. Couple things you need to know about nitroglycerin. It will cause a headache, and usually how we give it in this setting is we're going to give them a little tablet to put under their tongue and let it dissolve. It dissolves pretty quickly and can work very effectively that way. The other option we have is a nitroglycerin spray where we have them just open their mouth, lift up their tongue, and we put a squirt of nitroglycerin under their tongue. Again, so it's quick absorption and it works quickly. It can cause a headache. Here's the other thing. Nitroglycerin can cause a drop in the blood pressure, and that's due to its effective vasodilation. So nitroglycerin is contraindicated in patients who have a significant hypotension because it's going to make their blood pressure even lower. It's contraindicated in those taking medication to treat erectile dysfunction. There's lots of new ones out on the market. The most common one, I think, is Viagra. Viagra is also known as sildenafil. I'm trying to spell this. Sildenafil. Guess what? Sildenafil is a vasodilator. It can treat erectile dysfunction. It can also treat high blood pressure. So basically, if you give a nitrate to a patient who also has sildenafil in their system, you are going to cause a profound hypotension that could really lead to a shock in a patient, and could really be difficult to treat. So questions that you have to ask a patient prior to giving them a nitrate is whether they're on any kind of medication for erectile dysfunction. The interesting thing too is we have to be careful. Women are also taking some of these meds, so you have to ask everybody if they've had any kind of medication to treat any kind of erectile dysfunction. So just make sure you're aware of that can cause a blood pressure problem, so we have to keep an eye on that while we give nitrates. The other thing about nitroglycerin, we can give it under the tongue. We can give them a dose every 5 minutes. So we'll give them a dose under the tongue, let it dissolve. Wait 5 minutes, check their blood pressure, assess their pain. This is where you are going to be very, very diligent about having the patient rate their pain on a scale of 1 to 10. You have to have a very good documentation that you did this, because we want to know if it helped or not. Because, if it was a 10 out of 10 when they came in, we gave nitroglycerin, and it became a 5 out of 10, we know that nitroglycerin was somewhat effective. We give one dose, and there's still 5 out of 10. We can give another dose 5 minutes later underneath their tongue. Let it dissolve. 5 minutes later, we will reassess their blood pressure. We will reassess their pain. Now if it's a 1 out of 1, we're just going to kind of stay and monitor the patient. So we can do this up to 3 doses. And then, so in another situation, if you give a patient that comes in with chest pain at 10 out of 10, you give them a dose under their tongue. 5 minutes later, you check, and it's still 10 out of 10. So you give them another dose. All the while monitoring their blood pressure. You got the oxygen on them. You've given them an aspirin for that platelet aggregation inhibitor. And then we give them the 3rd dose. 5 minutes after the 3rd dose, that patient is still a 10 out of 10. You must get some more help. We need to call the healthcare provider. Because that's a very unstable angina. That means that the nitrates aren't working, so that could mean that we need to rush to the cath lab. Another medication that they might give in this situation, but you need to get an order for it, is your morphine. Morphine sulfate, you guys have seen morphine before. It is an opiate pain medication. It's an opiate analgesic. It's the drug of choice to help with pain not relieved by nitroglycerin for chest pain, because it also has some vasodilation effects as well as the pain opiate part of it. But it's just important to know that once you give that nitro three times and they're still in pain, especially if it hasn't been effective at all, you better call. And then we're probably maybe going to head to the cath lab depending on what the 12-lead EKG says. And they might order for you to get them. Because remember, we have to get their pain under control, because the more pain they're in, the more oxygen demand they have. So just real important to make sure we use those interventions. These are some diagnostic assessments that we're going to do. A lot of times they'll do a quick chest x-ray if there's time. Sometimes we don't have time to do the chest x-ray if if they have a ST elevation, things like that. If we have time, we'll do a chest x-ray, and that's just to kind of rule out other things and just for us to kind of have a quick view. Angiography and arteriography are diagnostic tests that will be done in the cardiac cath lab. Basically, what the angiography and arteriography are essentially the same thing. Basically, we go in and they'll go into a cath lab and inject a dye into the patient's vessels. It will illuminate the coronary arteries. It uses fluoroscopy and contrast media to illuminate the coronary arteries. This is a diagnostic tool. The procedure is performed when an arterial obstruction, narrowing, or aneurysm is expected. The interventional radiologist will present the dye into the the suspected coronary arteries, and usually done by, they take they insert a catheter into the left femoral artery and thread it up through. I think I have some pictures of this. They thread it up to the heart, up to the aorta, and then they inject the dye, which illuminates the coronary arteries so that they can indeed see if there's any kind of a blockage. This can be done in any arteries of the body. You know, if there's any kind of blockage suspected in any of the arteries, it's basically the injection of this contrast dye and looking under fluoroscopy, which is a type of x-ray, and determining whether we can see any blockages. So when they inject the dye, you should be able to see the dye go all the way through the vessel if it's open. If it's not open, you won't see it kind of go any further. So again, like we have some pictures to look at in class of this. It's kind of hard to explain just talking about it. But basically what this does is it allows us to see if there's actual blockage in the vessel, and we can see how much blockage is there. The cardiac catheterization is the most definitive and invasive test in the diagnosis of heart disease. Make sure that you review the pre-op teaching and post-op care of a patient who is undergoing a cardiac catheterization. Essentially, pre-operatively, it's just explaining what we're going to be doing, and that they're going to be laying flat on a table in the cath lab, and that there'll be some x-ray machines, which is the fluoro machines in the room. And then they will be given the contrast dye. And we need to make sure that we ask if they have any kind of allergies to shellfish or iodine or any kind of contrast dye, if they've ever had any problems with that in the past. We also will get them to sign a consent because it is an invasive procedure. Sometimes they will have a sensation during the procedure, such as palpitations, sometimes when the catheter is passed up through to the left ventricle. They can also have feelings of like a hot flash due to the infusion of the contrast dye that's injected into the vessels there. If there's time, we would show them, you know, like videos and things of what the procedure is going to be like. A lot of times we don't have time if we're in a hurry, if it's during an acute event. But if we do have time, we want to educate them about the procedure. And then we begin to educate them about kind of some of the things that are going to occur post-procedure. After the procedure, the patient will need to lay flat for a while. If we cannulate the right or the left femoral, or it's the right femoral artery, usually, we have to make sure that's a big artery and it has a risk for bleeding. So we have to make sure that we monitor that site very closely for the first 12 to 24 hours. Their activity will be definitely restricted for the next couple of days, just because we wanted to kind of baby that right femoral artery site that we've cannulated with kind of a big like cathing. And like I said, in class we'll bring some of this stuff so you can kind of see what they cannulate it with. So they're at risk for that big hole in their artery that we made, that it might bleed postoperatively. So we have to keep a really close eye on it. And for that reason, the same reason, we have to make sure that they lay still for a while post-procedure. The other thing is, of course, we'll be monitoring their vital signs. We'll be checking their pulses. So if we go ahead and we do something and manipulate that femoral artery, we always have to make sure that we monitor very closely the peripheral pulses distal to that site. So that would be your popliteal and your post-tib and your dorsalis pedis pulses. We'll monitor those very closely. We'll also monitor the color and warmth, the temperature of that extremity as well. So here's just kind of a picture of, again, that femoral artery. That's where we'll cannulate. They'll take the wire, and I have some good video of this that we'll look at in class. They'll take the wire and kind of go up through here and and take the wire up there and inject the dye while the patient is under fluoro, which is kind of like a continuous x-ray. And then when they inject the dye, we'll be able to see whether or not there's any blockages within the coronary arteries or not. At that time, whether if they see blockage or not, they'll determine whether intervention can be done. So basically, this arteriography and angiogram are essentially diagnostic tests to determine whether there are any blockages. If there are determined to be blockages, then we will proceed possibly, if possible, to do intervention, which would mean to do something to open up that vessel that we have found has some blockage in it. Interventions that can be done once we're in there and we identify that there is a artery that has a blockage that we can possibly fix. It's called intervention is called percutaneous coronary intervention. Specifically, percutaneous transluminal coronary angioplasty is essentially when we are up there with the catheter. We've cannulated the right femoral artery. We go up with the catheter, and then they take a balloon. They take a catheter that has a balloon on the end of it. The balloon is then inflated, and like I said, I have some pictures too that we'll look at in class to kind of further explain this process. Basically, the inflation of the balloon on the end of the catheter will push the plaque to the side to push it away to open up the artery again. Again, the type of intervention is going to be specific to where the occlusion is, in which vessel and which coronary artery it is, how big it is, the patient, things like that is going to determine what type of intervention is going to be done. An angioplasty is a balloon plasty, which, like I said, they inflate the balloon to force the plaque against the vessel wall, thus dilating the wall and reducing or eliminating the occluding clot. A lot of these medications listed here, heparin. This really depends on the procedure, the intervention itself, but these are some examples of medications that we might be asked to give post-intervention. Clopidogrel, I should be able to say that better. Clopidogrel is a platelet aggregator inhibitor. It works similar to that of aspirin. So basically, remember, platelets kind of are sent to the area to form a clot if it detects that there's an inflammation or injury to the coronary artery. So we want to prevent that from happening because that can further occlude the coronary artery. So the clopidogrel is given to prevent that platelet aggregation. Heparin is an anticoagulant. We'll talk a lot about heparin over the next few weeks as we talk about modules 9 and 10. Heparin prevents any further clotting from occurring within the cardiovascular system. And we don't want any more clotting to happen. We want the blood flow to stay open. Again, we know that nitroglycerin is a vasodilator, so that helps decrease chest pain, and it also vasodilates to open the vessel so that the blood flow can be maintained. Diltiazem is a calcium channel blocker. We'll talk about calcium channel blockers in the treatment of hypertension. Calcium channel blockers vasodilate the vessels as well. That's why they're a good post-intervention treatment for a patient with coronary angioplasty. Some more inhibitors. Basically what this is referring to, this classification of drug, is also a platelet aggregator inhibitor. I don't believe those are listed on your module outline, but there again, they would be given post-procedure to keep that vessel wall open and from clotting. Basically what's going to happen is the patient post-intervention is going to go home on some long-term therapy. Basically, and what the point of that is to keep that patient's coronary artery open and keep the heart from working too hard and keep the heart rate down, keep the blood pressure down. Because if we have an injured cardiac muscle, we don't want it to work too hard. High blood pressure is going to make that heart work harder, high heart rates. So that's why we might need to send them home on a beta blocker, ACE inhibitor, or ARB. That's going to keep their heart rate under control, keep their blood pressure under control. Because again, if we have an injured heart muscle, we do not want it working very hard as it recovers. Here's some pictures of what I was just talking about. This is the angioplasty. This is the balloon inflating, and it's kind of pushed the plaque out of the way so that now blood flow is returned to the cardiac muscle. This is a stent. This is another option for intervention. Percutaneous coronary intervention is what we're talking about. A stent can be deployed from the end of a catheter that is inserted through the right femoral artery and threaded up through to the coronary artery where there is a blocked vessel. The stent will be deployed, and the idea of the stent is that it opens up and opens that vessel up. Nursing care and medical care post-procedure of the placement of a stent is to maintain the patency of that stent. That is, again, platelet aggregator inhibitors such as aspirin. Clopidogrel is a very common one. It's also known as Plavix. Heparin, things like that is going to be what we're going to try to do. Our intervention is going to make sure that we maintain the patency of this stent. There is much research trying to perfect the stent. So there's drug-eluting stents, which means that there's drugs in it that when they implant the stent kind of the body kind of absorbs the drug that the stent eludes. The drug is usually directed at trying to maintain the patency of the coronary artery. There are often times that when we take a patient to a cardiac cath lab and we look at their coronary vessels, there are often times that there are too many occlusions for us to fix with just stents or angioplasty. Sometimes the cardiac interventionalist is unable to completely reopen a coronary artery due to where it's at, due to the kind of plaque it is. There's lots of different reasons. Sometimes it's just due to the anatomy of the patient's vessels that they can't actually get intervention by the cath lab. So sometimes a patient has to be sent to open heart surgery, and this is where they do an open heart coronary artery bypass graft surgery. So basically what this means is that we create bypasses for the coronary arteries. Vessels will be taken from a patient's leg. Usually they take a piece of their saphenous vein, or there's a artery they can take from the chest wall. It's called the internal mammary artery, and they can actually take that piece of that vessel. They can harvest that vessel and then bring it up to the heart, and they'll sew it off of the aorta. And so if there's an occlusion in a patient's vessel right here, they'll sew that vessel here, and they'll completely bypass this occluded area here. And by doing that, they have created an alternate route of blood flow to the myocardial muscle, so that now we can return blood flow. Again, this one is a triple bypass. This is where an internal mammary gland. I want to say internal mammary gland. It's an internal mammary artery that they have used to create the bypass. This is that artery that comes from the chest wall. Saphenous veins come from your leg. If you've ever known anybody that's had coronary artery bypass surgery, depending on when they had it, if they had it a really long time ago, they probably have some big scars on their legs where they harvested their saphenous vein. If they've had it recently, they usually do it now. They can do it endoscopically. So basically what they do is they make a few tiny little incisions now where they can harvest the saphenous vein much easier now than they used to. So this is what coronary artery bypass does. It creates an alternate route for blood flow when an occlusion cannot be reopened via a stent or an angioplasty in the cath lab. These are other diagnostic tests that can be done for a patient who presents with. These tests are usually more focused on a patient who is having stable angina. If somebody's coming in and telling us that every time they mow the yard, they get chest pain, and then they sit down for a half an hour and rest and they feel better. Sometimes we'll work them up a little bit more just to kind of see if we can determine exactly what's causing their stable angina. Of course, a 12 lead EKG would just kind of give us a baseline, give us a picture of maybe what we can, if there's any kind of issues we can see there. Electrophysiologic studies are basically studies where we, if somebody's having maybe a poor or an abnormal heart rhythm, we can that we saw on an EKG, we can assess that further with electrophysiologic study. Electrophysiologic is basically referring to the electrical conductivity of the heart. A stress test, you've probably heard of that a lot, and that's basically where we put somebody on a monitor, we monitor the heart, and then we make them exercise. So by doing this, we're kind of mimicking that mowing the yard. So if we can kind of induce some of that unstable angina, we can actually see on a monitor what's happening with their heart at the time that they begin having that chest pain. Is there ischemic changes? Is there ST elevation when this occurs? Just kind of helps us to determine exactly if there's anything happening that is big enough to affect their EKG, if it's big enough to affect EKG changes. Echocardiography is an echo of the heart. That's kind of like an ultrasound of the heart. You've heard of like ultrasounds for babies, to look at babies. An echocardiography is an ultrasound. We can take a look and look at the valves. We can look at the chambers of the heart. It kind of helps us to further diagnose maybe what is causing somebody to have some stable angina. Sometimes when someone is unable to perform exercises for a stress test, like a lot of times we'll put them on a treadmill. There are some patients who cannot do that, for different reasons. And so we might do an echo and we'll give them some medication that will stress their heart, sort of like activity, sort of like exercise. The medication will do that. And so then we can see how their heart responds to that type of stimulation. And that kind of, again, helps us to further assess what is causing a patient to have some heart palpitations or stable angina. This slide is meant to be a bit of a summary for interventions that a nurse needs to focus on with a patient who is presenting with unstable angina and signs and symptoms of a myocardial infarction. Interventions as far as drug therapy, remember that aspirin is given to prevent the platelet aggregation. We may possibly see thrombolytic agents given. This typically occurs, so thrombolytics means that it can break up a clot. Those medications are listed on your module outline. That's streptokinase, it's TPA. And basically those medications are given intravenously to bust up a clot. The only time we give these thrombolytic agents anymore is if we are at an outlying facility where a cath lab intervention is not possible. In that instance, they may infuse a thrombolytic agent in hopes of busting up a clot that might be occluding a coronary artery in order to restore blood flow. And again, this is just a summary statement here. Restoration of perfusion to the injured area, limits amount of extension, improves left ventricular function. So our goal always in our intervention is to restore that perfusion to the injured area, and we have to do it quickly. The longer that injured area is deprived of oxygen and blood flow, the more likely it's going to have permanent damage. And this, just because we've done a lot of research on this, and we now have the ability to quickly return blood flow to the coronary arteries. MI has decreased more a few hours. Since we can do it quickly, we can do it. It's decreased the mortality of our patients. We've saved a lot of lives by doing this. This is just a quick review of those thrombolytic therapies that I mentioned. And again, usually in the case of a myocardial infarction, the only time we are giving these medications, and these are IV medications, is when a patient is in an outlying facility, possibly, that we don't have quick access to a cardiac cath lab. Thrombolytic medications such as alteplase, retaplase, tenecteplase. They are thrombolytic medications used early in the course of myocardial infarction. They have to be used within 4 to 6 hours of onset of the infarct to restore blood flow, limit myocardial damage, and preserve left ventricular function and prevent death. There are contraindications to the use of these medications. If anybody has a history of any kind of a hemorrhagic brain attack, which means a stroke that from a brain bleed, any kind of intracranial trauma recently, like brain trauma, head trauma, any kind of major surgeries like intracranial or intraspinal surgery within the past 2 months. Basically, the reason this is because these thrombolytic drugs are going to make them bleed, make them at risk for bleeding, because we're administering a medication that has the enzyme that dissolves clots in it. Some other contraindications are uncontrolled hypertension. And the side effects of these meds are that it can cause bleeding, dysrhythmias, and allergic reactions. And again, so this is kind of why we've kind of moved away from this med and done interventions, is because there's a specific window. You have to get them within the 4 to 6 hours of the onset of the infarct. And then you also have to make sure they don't have any of these contraindications for giving this med. Bleeding is a primary concern for these, so they are monitored very closely by the nursing staff post infusion of these medications. You're monitoring vital signs. You're monitoring their clotting factors, such as their platelet count. You're monitoring their prothrombin time, which helps us measure clotting time. Monitoring them for any kind of bleeding, looking for any kind of blood in their stool, neurologic changes that would indicate a brain bleed. You want to monitor, make sure you do a little bit of prevent any kind of injury. Make sure they don't use a straight razor. Make sure that you're not sticking them a bunch for lab results and things like that. So there is a little bit of danger involved in administering these meds, and they're typically only used nowadays when a patient is at an outlying area who we don't have access to a coronary intervention. This slide is specifically talking about a patient, drug therapy for a patient who is post-MI. So they've basically had a myocardial infarction. They've had an injury to their heart due to a blocked coronary artery that decreased blood flow to the area for a small amount of time. These patients will go home on these medications listed here. We'll talk about some of these medications more specifically as we talk about hypertension. Beta blockers are also known as beta adrenergic blockers. They sort of inhibit the response of beta adrenergic stimulation. What this means is that it kind of blocks the beta receptors in the heart from responding to stress stimulation. It blocks the release of catecholamines, epinephrine, and norepinephrine. And remember what norepinephrine and epinephrine do is they kind of like put you in that fight or flight response. They make your heart rate go up. They make your blood pressure go up. And so by giving them a beta adrenergic blocker, we block those catecholamines from doing this to your heart The reason we want to do that is because a patient who now has an injured area of their heart, we don't want to put them in a state of increased oxygen demand, because that's what this fight or flight response does. It increases your oxygen demand of your heart muscle, and we don't want that increased oxygen demand to occur on a patient who has an injured heart. We want their heart to just stay nice and chill. We want a normal heart rate. We want a normal blood pressure, because the more the heart rate goes up, the more the blood pressure goes up, the more the oxygen demand and the workload of the heart stress that injured heart. So we want them to stay, we want to give them a beta blocker to keep them nice and calm. The problem with this is that a patient could experience some bradycardia due to it does lower your blood pressure and your heart rate. So you want to monitor your patient for any bradycardia. You want to monitor their blood pressures to make sure that they don't experience too low of a blood pressure. Sometimes it's a little bit tricky to find that balance between making sure they're chill and making sure they're not too chill. So we have to, kind of keep an eye on that. ACE inhibitors, also known as angiotensin converting enzyme inhibitors. ARBs essentially do the same thing. They're angiotensin 2 receptor blockers. They both have essentially the same effects on the patient. They are often given post myocardial infarction because they have somewhat of a cardioprotective effect after a myocardial infarction. They keep the heart rate nice and normal, and they keep the blood pressure nice and normal. That's kind of their cardioprotective effects. They prevent peripheral vasoconstriction. And they work in that area of, remember how the adrenal glands secrete aldosterone, and aldosterone controls blood pressure by controlling fluid and electrolytes. So these kind of inhibit some of that effectiveness of aldosterone. They kind of take over for it and make sure that the patient's blood pressure stays nice and normal. There are some side effects of ACE inhibitors. They're famous for their persistent dry cough that they create in a patient, and sometimes people can live with it. Other times they cannot. If they cannot live with the persistent dry cough of the ACE inhibitor, we will simply switch them over to an ARB. The ARB does not have that side effect, and like I said, they essentially have the same effectiveness for a patient. They essentially work about the same, so we'll just switch them over to an ARB. Other side effects is it can cause, you have to watch your elderly patients with ACE inhibitors. It can cause a dizziness and orthostatic hypotension, especially when they first start taking them. So you have to make sure they monitor their heart rate and their blood pressure. It can cause a safety issue, and especially the older your patient is, due to the dizziness that it can cause. Like I said, especially when they first start taking them and their body's kind of getting used to them. There's another important side effect that is rare but can be life-threatening: angioedema. Remember what angioedema is? It's kind of like when people have an allergic response. ACE inhibitors can cause an angioedema just in somebody. It's just kind of like an allergic response, and that is an emergent situation that would need to be reported right away. Calcium channel blockers might be a medication that's also utilized in a patient going home post myocardial infarction. All of these meds are given as a cardioprotective treatment in order to make sure that the damaged heart, the injured heart, does not become any more damaged. Calcium channel blockers decrease cardiac contractility. They decrease the workload of the heart, and they decrease the need for oxygen. So it kind of lets the heart rest. Again, this will lower your blood pressure. So oftentimes a patient needs to be taught about signs and symptoms of low blood pressure. They need to be taught how to take their blood pressure to monitor and make sure that it's not getting too low, because the dose might need to be adjusted. Calcium channel blockers are sometimes used in a patient who has a stable angina as well, because like we said, they are used for angina and they decrease the workload of the heart, thus decreasing the need for oxygen. So it can be an effective treatment in a patient who has a stable angina. That's just a good thing to keep in mind. Anti-lipemic medications are given to reduce serum levels of cholesterol, triglycerides, and LDL cholesterol. When cholesterol, triglyceride, and low-density lipoprotein levels are elevated, the client is at an increased risk for coronary artery disease. It can also be given post-event due to the statins specifically is what I'm speaking of. Those medications are given after a myocardial infarction due to the fact that they are believed to have some anti-inflammatory properties to it. So after an MI, a patient might be put on a low-dose statin, even regardless of what their cholesterol level is. They do it just to kind of as an anti-inflammatory effectiveness, because remember, if there's injury to the vessel wall, there's that inflammation that can occur that can cause further blockages of the vessels. I put statins on here just because they are the most common medications utilized in this case. Atorvastatin, pravastatin, simvastatin are very common ones. There are some side effects of it. They can cause nausea, diarrhea, or constipation. They can cause abdominal cramps. There is a life-threatening side effect that is rare but can occur, and the patient needs to be educated to report this if it does occur. It's any unexplained muscular pain to the healthcare provider. So any kind of severe, sudden muscular pain, it could indicate that the patient is having a serious adverse effect of the statins. Muscle cramps and fatigue can lead to unexplained muscular pain that needs to be reported immediately. The other thing about the statin drugs is they can cause elevated liver enzyme levels. Again, it's kind of rare, but it is pretty important to keep an eye on. So basically, a patient who is put on a statin for long-term therapy will need to have their liver enzymes monitored. Typically, they do it about every 6 months when they first start them on it, and then they will, if they do have normal results, they'll switch it to every year. They'll check their liver enzymes with these medications. One thing that is very important for you to think about as far as a cardio, assessing a patient about any kind of cardiac abnormalities is knowing the normal lipid levels. Know that cholesterol levels are thought to be a direct risk factor for coronary artery disease. And so to know those normal levels in order to be able to educate your patient about them. Typically, the desirable range for serum cholesterol is lower than 200 in a patient. So that's your total cholesterol. So that should be less, and this is your majority of your patients. The LDL cholesterol, so the cholesterol is further differentiated out into LDL cholesterol and HDL cholesterol. This is low-density lipoprotein cholesterol. We want that lower than 130 in most patients. And that's because low-density lipoprotein cholesterol is the type of cholesterol that takes the cholesterol and deposits in the coronary arteries. The HDL cholesterol, we want that level to be 30 to 70. This is your good cholesterol. This is the cholesterol that takes your cholesterol and deposits it in the liver, which metabolizes it and rids it from the body. So that's why. So that is why we not only take the total cholesterol, but we also look at the low density and the high density lipoproteins. If their total cholesterol is 200, but their low density is maybe, say it's 180 and the LDL cholesterol is only 20 of that 200, we need to fix that because That means they have more bad cholesterol than they do good cholesterol, and they could still have major risk for coronary artery disease. Now, one thing to note that these levels are based on the healthcare provider guidelines, because if we identify that somebody has a super high risk for coronary artery disease, we might even want these numbers lower in somebody that has a multiple other risk factors. So it's just important to make sure that you have an idea of what normal cholesterol levels are so that you can effectively educate your patients on these. The following slides are questions to review the content that was just covered. I highly encourage you to review these, try to answer them. The answers to these questions are posted in the PowerPoint that's posted under additional resources. I look forward to discussing all this material further with you in class. And please always email me if you have specific questions or having specific difficulty understanding a concept. I am happy to help. This concludes this presentation for Nursing 150 Module 9.